Hello everyone, I'm Andrzej Pilat and I would like to present my new book. This is related to the scientific and clinical reasoning focused on the structure and function of the fascial tissue. The book is published by Handspring Publishing and is titled Myofascial Induction, an anatomical approach to the treatment of fascial dysfunction. The book is published in 2 volumes. The first one was published a few days ago and it is related to upper body treatments. And the second volume focuses on the lower body and is in the last phase of editing process. The book has QR codes inserted so you can access it in your phone, tablet or computer and watch videos of fascial anatomy dissections and practical application of the clinical procedures. The book has large content linked to the scientific approach and sometimes the text can be a little heavy and for this reason we have attached an extensive glossary to the book to facilitate reading and thus know exactly what is the meaning of the words that scientists sometimes use in a way that is quite enigmatic to us. Once again, as you can see, the glossary is quite extensive. The first part of the book focuses on the theoretical aspect related to the fascia. We want to look at the scientific evidence for each of the properties of this tissue, and I mean trying to answer some important questions. Is it possible that fascia actively participate in body movement? Keeping in mind that movement, I don't think in the movement of the arm or our locomotion. Movement also means the digestive tract activity, the breathing action, or the performance of the cardiovascular system. Based on systemic reasoning, we can say that the fascia is the tissue that joins all these actions, communicating body structures with each other. We will then analyze the theoretical contents of the book. I want to explain why we are talking about the fascia and not about another tissue. Later, we will try to define the fascial structures, define the model of body movement, and then we have to rely on the most important pillars when talking about any type of event in our body. I'm referring to anatomy. I'm referring to biomechanics, I'm referring to histology, and I'm referring to the innervation. Next, we will focus more deeply on what type of movement models are we using, analyzing how the fascia interacts in the process of movement. I have in mind the musculoskeletal fibers. Remember that these fibers are not fixed directly to the bone. It needs something to communicate it to the bone, and that something is precisely the fascial structure. For that reason, we have to talk equally about the neurodynamics and the histological aspects. The first chapter of the book focuses on the question, why this book? Is there really any reason for its existence? The book is very extensive. The first volume consists of almost 600 pages, about 700 images and anatomy pictures, anatomy from non-embalmed cadaver dissections. The analysis of the anatomy is not in non-embalmed cadavers allows us to approach the reality of the movement of a living person, analyzing the biomechanics movement of the healthy body, as well as pathomechanics, referring us to the body with diverse dysfunctional pathologies. In chapter 1, we start the analysis with Biomedical model, which is widely used in daily practice. I'm not denying its usefulness, but it's really valid to explain all aspects of the altering movement along the disease process. Really, this model is valid today in front of the neurological, neuroscientific evaluation. In light of the fact of the biomedical model could not explain the complex nature of health condition, the second one is biopsychosocial model incorporates more elements. In this model considers 3 domains in the understanding of the heart disease and health care. And recently, the third model, an active model, has gained ground. Scientific progress affirms that the body is a dynamic whole embedded in an environment. In this way, the mind is not only connected to the body, but also the body influences the mind. This model is influenced by two basic segments: the impulse that comes from outside, I mean the exteroceptive information, as well as the information that we receive from each our body cell. I have in mind the interoceptive process. In this way, we approach the analysis of the construction of behavioral system, systemic reasoning, in the process of healthcare. This is the second chapter. An example of this reasoning is cancer treatment. Cancer cells can affect different organs, the lung, the liver, the stomach, etc. In the past, treatment focused on a certain organ that was affected. In recent years, however, systemic reasoning predominates and therapy is directed mainly at the certain type of cancer cells and not so much at the specific organ. Since then, the systemic reasoning prevails throughout the pages of the book. For this reason, do not be surprised that we are going to talk about the skin, the behavior of its tensional line, Langer's line. We also talk about the fat that is under the skin that seems to be much more important than we have thought. We include in the analysis other systems present in the dermal and subdermal level, such as circulatory and neural system. And then we are approaching to the third chapter of the book, which is perhaps the most important because it talks about fascial anatomy. As I mentioned recently, I was talking about the anatomy that we carry out with the dissections of the non-embalmed cadavers, protected and preserved at a low temperature, about 2 to 3 degrees Celsius, or they were frozen cadavers, that is with the temperature about 30 degrees Celsius below zero, and then taught for anatomical work. All the anatomical images that you find through the book, more than 350 images, show no embalmed specimens. The anatomical analysis of the fascia with embalmed cadavers, for example, in formalin, from the topographical point of view, is quite accurate. However, what I'm looking for in this book is to demonstrate the continuity of the fascial structure and its relation to other tissue. And this is not an easy task on the formalin embalmed cadaver. Let's go deeper into this. Please observe. You are seeing an analyzing of anatomy of the body starting from the structure of the skin. For example, a scar. The scar, perhaps of secondary importance, could influence the dynamics of joint. A Langer's line, which are tensional lines which maintain the skin in the state of continuous pre-tension, are answering this question. The vast range of scientific research that we try to analyze through the pages of the book affirms that this is really feasible, that is, a traumatic impulse at a superficial level can generate changes at much deeper level over time. And observe, please, we perform the analysis not only of the specific part of the body. We try to focus on all structures, such as entire trunk, for example, the lower extremity. We are analyzing and comparing the cross-sectional of each level with the entire longitudinal path anywhere, not only in the extremities, but also, for example, in the trunk. This analysis open up different horizons of reasoning. The body is carried out in movement. Please observe the changes at a very superficial layer that may be linked, for example, to aging process. They may be related to inflammation. They may be related to edema, or they be related to ptosis. How the structure influences the dynamic of deeper layers and affects the action that I want to perform. Sometimes the recognition and analysis of the anatomical samples on the non-embalmed cadaver is not an easy task, so we often help ourselves with graphics. The root of fascia, particularly at the superficial layer, is not the same throughout the entire body. For this reason, we are looking for the anatomical differences in the fascia between parts of the body. Look at in each part we are also influencing the reasoning towards different pathological processes. For example, we can look to the knee, observe here, we have a cyst and the level of the bursa, or we also pay attention, for example, to the circulatory system, the venous and arterial structure, as well what it can be seen in lymphatic structures, the veins and the deterioration process or dynamic of the veins themselves in the movement of the inside of the veins indirectly linked to the fascial structure. So the capillaries present under the skin are also relevant in the analysis, and for that reason an extension part of the book focuses on the theoretical knowledge so that later it can be useful when you are suggesting the specific clinical procedures. That is why I'm always considering that first of all we should explain any body activity first of all from the anatomical viewpoint. For the reason many pages of the book are focused on anatomy in chapter 3, but not only in this chapter. Later, we focus on the clinical performance. The anatomy samples of non-embalmed cadavers will also accompany us. Here we have the deep fascia. This is fibrosis, very different from the superficial fascia. Is the course of fibers important? For example, if they are more densified or their path runs in the wrong direction, they can distort effectiveness of correct contraction of the muscle fibers that it surrounds. Is it possible that the movement alteration is not mainly due to deficiencies of the muscle fibers, but it's also fascial wrapping at all layers of the muscle construction? It will be all in the action? We continue with the anatomy, and we are looking to the deeper level. For example, in the right side, you can observe the lacertus fibrosus of bicep brachii, the bicipital fascia. Observe how the direct transmission from the fascia to the fascia is taking place, totally omitting the connection between bones, and which is another form of transmission, parallel to the transmission by tendon to tendon connection. Here we have a dissection of the lower extremity at the level of the deep fascia. We can observe the cross section in the cadaver, but sometimes we can get confused because it is not seen with accuracy. Since the cadaver is highly hydrated, and then a certain collapse occurs due to weight of the action of gravitational force. That is why in the book we are also placing different diagrams so that it is a way we can verify the anatomical observation and continue with the analysis in a much more exact way. We finished the analysis of the chapter 3, the fascial anatomy. As you can see, it was about the 100 pages, so this section occupies a large part of the book. The chapter 4 talks about embryology. The subject is quite complicated before the fascial point of view because there is a little information related to it. What we know is that the fascia is born from primitive mesoderm, but there is not much more information, so we try to find scientific evidence, focus of the movement, different types of pressure, and mechanical tractions, and they are present in all stages of the development of the fetus, constructed the fascial tissue structure. It is a fairly novel approach, and the information we have is well accompanied by scientific evidence, and I think it would be very useful for you. We accompany the content of this chapter with the recent scientific bibliography. The 5th chapter focuses on fascial histology. Here we talk about the connective tissue matrix, We analyze the interstitium. We focus on the cells, the fibers, the receptors. Here is the flow chart. There are many of them in the book linked to different forms of connective tissue until we get to the fascial structure as a form of connective tissue. Not all connective tissue is fascia. We try to analyze the fascial structure at the macroscopic level and also looking at the microscopic level. We accompany this analysis with the drawings that indicate the complexity of the connective tissue matrix. Of course, we mainly focus on the structure of collagen, its shape, how that shape changes according to the different movement or lack of movement, tissue damage, for example, how it influences the dynamics of the connective tissue and the dynamics of collagen. We are looking to the different chemical changes and of course also biomechanical and hormonal. All of these processes we are analyzing closely in this chapter. However, perhaps in this chapter and at the histological level of analysis, the most important question we ask is the following. Is cellular communication important to analyze body pathomechanics? How do cells communicate with each other? Does communication only come through chemical electrical impulses? Is important the mechanical impulse which is present in the cell's communication? Can the deficiency of mechanical communication between cells be replaced by another type of communication? So we analyze form of mechanical communication between cells, what happens at the moment when the practitioner hand is placed on the body in manual application. Is the impulse received by the receptors and also received by the cells? Again, it is very difficult to talk about this topic, which is why we have to support the scientific evidence. What mechanical model do we use? Is the two-dimensional model of plane, axis, and lever enough for understanding fascial movement? At no point is the goal to deny the Newton's laws, of course not. However, we propose a different model of tensegrity model. The tensegrity model is based on architectural concepts. However, we should not be surprised by the fact that it is present in different types of scientific studies related to the biology and the body movement performance. Analyzing the anatomy of the body, we always talk about architecture, that is the form of construction. How are the forces distributed in the subject? How do the forces complete each other? How are forces transmitted? This model is useful in biology, particularly in the molecular biology. The research shows that this model has helped us to analyze fascial system behavior. In the living structure, such as our body, the deformation of its constituent element is the basis of movement. The muscle deforms when we move, the bladder deforms by accumulating urine, the uterus deforms during pregnancy, the plantar fascia deforms when we are walking. Tensegrity is mechanical model that integrates the deformation at all level construction of our system. So I go to invite you to read closely this information. I think it's the big help during the practice. The chapter 7 talks about a phenomenon that in the last years help us better understanding the body kinetics. I'm referring here to the path of the contractible impulse from muscle fibers is transmitted to the rest of the system. Considering that no muscle fiber is attached directly to the bone, is the communication from one tendon to another tendon and muscle belly between them the only model for the muscle contraction, muscle action? Or is there also some other type of communication inside the motor-skeletal system? We analyze here different types of concepts, and again, starting from the anatomical analysis, we find a very curious situation. If I make an anatomical preparation and completely eliminate the fascia, I can see the tendons here. We are at the level of the carpal tunnel. I identify very well and very clearly the tendon and the muscle and the nerve and the blood vessels. I wondered if analyzing this movement as a kind of rope that pulls the bone, for example, is it a complete model of the muscle contraction? Can we understand the contraction in this way? If I'm looking to the same area, but from other points of view, meaning I'm not going to remove the fascia here with a scalpel or with scissors, I'm not going to cut it, and then I find lateral tendon to tendon and muscle to muscle connections. So, then I ask myself, if a muscular belly contracts and is pulling the tendon, what happens with the lateral communication? I mean, what are the model that I'm using in this concept? How do I really understand movement? For this reason, and as you have noticed in the book, we use a lot of diagrams. Why sometimes the text can be very long, and we need a quick review of what we have already read, and we try to focus this reasoning and compress the information in an outline that I think will be very helpful for the readers, so we can analyze each phase of those movements and present with this diagram. Now we move to the chapter 8, the fascia and the neurodynamic response. The central and peripheral nervous system are not out of analysis and are present in the book, occupying an important part. On this topic, we have information from recent years from the research where it is clearly being indicated that the fascia is an active structure in the nociceptive process. That is the way we understand, perceive, and experience the pain, including very recent research, which are pointing that at least in specific parts of the body, for example, in the lumbar region, the superficial fascia, which is located at the subdermal layer, or the fascia, which is located at the deeper layer, for example, thoracolumbar fascia, both could be the source of the pain. Even a very acute pain that doesn't have to come from a compression of the nerve, such as the sciatic nerve, which could be trapped between the fascial structure in any location, including the most superficial structure. So, we try to see the different concepts of understanding pain. We asked what kind of sensitization is present in this process. What type of information through the network of the receptors fascia transmit to the brain, and what happens when the peripheral area is affected. The question is the movement important for the brain? How does the brain act if the movement is stopped? Does the brain think that this movement that I'm like to will perhaps cause pain? How does the brain act, and how can the fascia react to the brain guidelines? For that reason, we focus on a whole range of receptors that are present at the deep layers. And also we are present at very superficial levels, such as Merkel receptors, and of course we are looking to the discovery of interstitial receptors. They are free nerve ending, the fibers A and I delta and C fibers that are directly participating in the sensation of pain. The question we should ask is how the soft pressure, the therapeutic touch that we apply throughout the session over the patient body reach the brain. This process is also related to the pain control. Does the fascial tissue participate in the traumatic process, pain sensation, and healing progress? That is, participate actively? In order to answer this question, Once again, we create these diagrams. We ask ourselves what are the factors that could injure the fascia. Is the trauma related only to a blow or fall or an injury or surgery, or perhaps it is also linked to our way of eating or the way of carry out daily movements, or perhaps our age of and hormonal changes that occurs in our body. For example, in the female body during the pregnancy process of during menstruation. These are the questions that we try to answer, taking into account the scientific evidence that we have at the moment. And the results are quite interesting and very optimistic. I think that they are opening a horizon for us understanding better this pain. Now we're approaching the chapter 9, Fascia and Trauma. This is very interesting. There are a lot of very interesting questions. Does the fascia participate in the traumatic process? Another question, is fascia involved in the healing process? Participate in this healing process actively? Answering this question is not an easy task. Again, in order to answer the question, once again, we create these diagrams. We ask ourselves what are the factors that could injure the fascia? Is the trauma related only to a blow or fall or to an injury or surgery? Or perhaps it is also linked to our way of eating, or our way of carry out daily movements, our walking, or perhaps our age and hormonal changes that occur in our body, for example, in the female body during the pregnancy process or during menstruation. These are the questions that we try to answer, taking into account the scientific evidence that we have at the moment. And the results are quite interesting and very optimistic. I think that they are opening a horizon for us to understand pain better and better. To get into this process, we analyze the fascial microstructure. We create diagrams which show how all the components and micro-components of the extracellular matrix, for example, are participating in the aging process or in the healing process of the wound, I mean the formation of scar, and we do not forget small elements at any time. I'm referring to those elements that many times, not the text is quite broad, the small elements are equally present in each movement we perform, equally in biomechanics and pathomechanics. And to conclude the discussion of all these pages, here the diagrams that the reader can use to review and deepen or perhaps even treat them as initial understanding that allows to return to the text to deepen that information and be able to use it directly in the clinical practice. This beginning of the objectives of the book. And once you can see, we have large support of the scientific evidence in this subject. We have reached chapter 10. It is a chapter of great importance for the book. How to assess the fascia? Can I assess it an isolated structure? Right now, we don't have the specific tools to assess fascia behavior separately of other structures. Even what neuroscientists report, the innervation of the fascia is not exclusive. The assessment of the fascia follows the models of body movement assessment related to the musculoskeletal system, of which fascia is an integral part. The patient should be an active participant of the assessment. The treatment process begins in this moment. The practitioner and the patient acts together during the process of assessment and also during the treatment. They observe the changes and analyze the progress. For this reason, observe that from this huge algorithm, we take small segments and analyze each one separately. It is quite an extensive analysis, as you can see. We also use many tables in which the information is very condensed along this chapter. Before carrying out the test, we analyze its scope and form the application, as well as its interpretation. And of course, the scientific evidence that allows us to later guide us in clinical decision throughout this entire process. And you can see along this chapter are many tables of this type, and they are very helpful since they contain a lot of condensed information. The nervous system is not out of our attention. Of course not. That's why the neural system that the tests are also present and described. And finally, in this part, I would also like to point out the importance of focusing on the gastrointestinal system. The clinician who is assessing the patient at a given movement does not allow have the competence to create some types of specific response. I mean, reach a clinical conclusion and give a diagnosis. Each of us can do it depending on the level of understanding and professional training that we have. However, I think that in relation to the digestive system and the pain at the level of the abdominal area, perhaps we should be more aware of the red flags. That is why we use the ROM4 here, which is the base to analyze different types of signs and symptoms, and in this way to know how far the clinician competence goes. I already mentioned the circulatory system, for example, the lymphatic system that also should be explored, and of course the essence is the assessment through movement. The assessment of all the body, and in this way I can explore completely all the system that are important and related to the fascia. So in this chapter 10 talks about the general assessment, which we then use for the upper and lower body, and it is perhaps the chapter that contains the big number of biographic references, thus giving us very interesting endorsement, telling us what contemporary science thinks about how to assess the patient. The treatment goals are outlined in Chapter 11, and Chapter 12 attempts to summarize the evidence of MIT treatment. Each chapter starts with the introduction, sometimes with almost philosophical approach, focusing the body movement to development of the human movement, behavior, and the role of fascia in bipedal posture and locomotion. And then we show the evidence available at the moment in the application of myofascial induction techniques. Here we have once again extensive references as you can observe it. Once this brief and quick analysis of the theoretical part is finished, as you can see, the content of the book is really extensive. And now we move to the second part of the book related to the practical applications. The clinical applications for the upper body. Remember that the lower part corresponds to the second volume of the book. So in order to therapeutic consideration, we are again creating diagrams that will guide us throughout this process. We are talking about different types of basic techniques application that, remember, there are key tools to later build up a treatment process. I don't want to use the word protocol too much, although in a way there will be protocols, but they are very open protocols that allow the professionals to adapt their knowledge to the particularities of each patient, focusing the treatment to the patient's system, not just to the symptom. This is the idea. So we analyzed the reactions during the clinical application, for example, in the collagen networks dynamics or the fibroblast dynamics. The table show the follow-up with the treatment objectives. Here you can find the observations for the clinician and then how the technique is performed. Each of these parts is explained in the table. The text also makes this information very clear, but the table always helps us a lot. Here very quickly, simply so that you can see that each of the techniques is accompanied by different images, and in this way you can clearly have the correlation between the text and the clinical part. This part is extremely important in the book because and it took a lot of work to make it as clear as possible, because here comes the question: what happens during myofascial induction treatment? How does this process respond? What part of the tissue is acting? How are different types of cells or different types of anatomical elements communicating through the fascia throughout this process? So based on all the information from the first part of the book, which is, take a good look, 250 pages, we are trying to summarize that in these diagrams. And the final diagram, which is very clear below, tells us that the fact of touching the patient means that we touch an organism, we touch an organ, we touch a cell, we touch a genome, we could also touch the different molecules. And this structure in each phase of the treatment gives us feedback that allows us to modify the therapeutic process, fine-tune the therapeutic process through its path. And in this way, we try to introduce the theory and the unit, the clinical analysis. As you can see, the texts are quite extensive and allow us to underline the extended information to go beyond the details. The chapter 14 is the reasoning of the assessment of the upper body. As we have seen previously, the chapter 10 shows us the general assessment process, but this one is already adapted to the upper body. Once again, in more tables, diagrams, and also tests. Of course, we do not leave out in any time the nervous system equally, the peripheral level, deep level, superficial level. We analyze how different movements are transmitted to the brain, how the brain reacts. Again, we always locate a neural structure, what are the nerve endings, what is its sensory distribution, and also how it participates in the dysfunction process. What are the deficiencies? And we always try to support each of this information with the most recent assessment based by scientific research. The chapter 15 focuses on the craniofacial and the neck areas. We do not separate the dynamics of mastication from the movements of the neck, so we join the cervical segment with the craniofacial area. We consider that it really has a lot of relevance due to the fact that the same structures that govern the movement of the cervical segment participate directly in the chewing movement and also vice versa. Once again, we use anatomy samples, diagrams, always in order to simplify the reasoning. We have here, for example, an image of the temporomandibular joint and the disc. We also have some drawings that show how the ligaments work, anatomical images, diagrams, drawings, the fact that this area is not easy to understand, such of the platysma, for example, to understand that this muscle is such a direct participant in chewing movement. After we gradually move on the neurological part, how do the different types of neural distribution center act? And again, very important through the course of the book, we have more tables. Please note here there are very clear talking about pain and orofacial dysfunctions, the location of the pain, the patterns, the description of pain, and of course clinical approach to each of this segment we'll show you now. On these tables we compress the information of many pages of the text, and you can quickly check the information. And again, in the second part of this chapter, there is a structure of the cervical system. So if we talk about the area, we also talk once again about the skin, about tension, lines, and we follow the structure of the central nervous system, a peripheral nervous system, and also to analysis of meningeal behavior. We present here, since it's very difficult to observe it in an anatomical image directly, Some drawing of fascial layers. The cervical segment, transversal section, as you can see here in anatomical image of cadavers, and also in the diagram to facilitate the analysis. Different types of anatomy images. For example, in this part, we try to carry out the dissection by segment or by layers, so that it is understood what happens from the platysma to the deep structure of the cervical area. And this way we have better knowledge of what we are touching in each moment. What amount of force do you need to assess it? Which structures might respond if you applied a higher intensity of force? What structure is currently involved in this process? That would be the goal. And after that, we are going through theoretical part of the cervical segment. We move to the practical application, so that it always a glossary of all procedures, and we have a diagram that is repeated in all of that, in all techniques. First, this is an approach to the assessment, a general assessment for this segment and the theoretical analysis for meninges. So we do not leave the skull structure, for example. And that is a diagram that is repeated later throughout the book in relation to the clinical applications. I mean, we have an image of the technique. If is very precise anatomical location is needed. Here, for example, a bone, and then the place of the fascia. Then comes the analysis of the objectives, and we step by step observe the type of procedure, indication, and how to analyze the red flags. How could the patient respond to the application of this technique? What kind of precaution must be taken? And there is always the same form of description. A position from the patient, a position of therapist, what is the position of the hands, how is procedure performed, and then the analysis of the results. What kind of decision must be made? As you can see here again, the shapes of the skull bones are well marked, and of course the fascial anatomy is always present as the total protagonist of each of these techniques. Here, the sagittal section along the skull, and in this way, for example, we see the application of the technique at the level of the temporomandibular joint and the cervical segment, and each technique has its own page, as you can see, and each page allows you to return whenever you have, for example, some inconvenience, a reaction that we do not expect from the patient. This type of quick analysis allows us to locate ourselves very well where is the problem, and in this way, of course, improve our work. From this point of view, for example, in the application of the technique, the anatomical image is present, but there is also a diagram that tells us very precisely and clearly where they place the fingers, where they place the hands, what kind of movement do we have to make. Now we approach to chapter 16, which is related to the complex of the thorax, in which, of course, the breathing movement and function of the thorax as a protection from different bodily reaction is present. We are also using through the book also ultrasound or magnetic resonance images, although there are not of many of them. And please take a look at what I just said about the pectoral region. The ribs, the pectoral major, minor, we try to go from very large to the details where, for example, you can see that the intercostal spaces, the fascia of the intercostal muscle is continuous with the periosteum. In this way, this globality of body response and the absolute continuity of the fascia is put in evidence. As I said before, in situations where there is some kind of difficulty in anatomical reading or a certain degree of complexity of the technique, we place help in the form of a QR code, so that you can see the application in video, the anatomical image with the movement, and this way to have a much greater focus and security in the application of the technique, and to know in which part of the body you are working at each moment. Observe here this would be the level of superficial fascia, the deep fascia. We remove here the trapezium of the back. We come structures, for example, of the fibers, the course of infraspinatus fossa, which is absolutely spectacular and perhaps the most complicated fascia of the entire body in relation to the musculoskeletal system. Again, the applications with images, or again the QR code, and again the same scheme of procedures. Chapter 17, the last chapter of the book, that talks about the upper extremity. You already know the procedure looks like, so we are not going to repeat it. Just want to say again that we are talking about the entire structure, the neural as well as the muscular and circulatory components. And again, here we analyze the extremity. Here is the cross section. If I can demonstrate the continuity of the fascia from the neck that reaches the palmar fascia. And there it is a large image and also everything separately. So you can see each of the segment, and we also make a cross section. Then we use here a picture. This is the digitalized drawing. Based on the dissection, we can observe the cross section also. However, when we move to the procedures, we previously analyzed the cross section with each of its components. What is the location? What are the barriers? What do they consist of? What do we really use it for? And also the biography references. And then the cross-section are present in the text, as you can see, already with the anatomical approach, many times showing the details. So in this way you can observe with a great accuracy not only what I palpate at the superficial layer, but also what I can palpate deeply. Look at the spine of the shoulder blade, so spinatus, infraspinatus muscles, what are the relationship between the fascial structure of each of these items. Again, with high resolution close-up images showing the deepest part of the body. For example, you can observe the ventral aspect of the arm, the forearm, also the wrist with the carpal tunnel. So here's some examples of therapeutic processes. We can observe an index of the techniques which facilitate the review. You can also find anatomical examples with precise description, and note that we repeat the same order. Here we look at the anatomical images, the drawing of the component, the position of the fingers, the description of the clinical application for each of the parts that we are discussed at the moment, what is of interest to you in the therapeutic process, accompanied once again with QR code. Observe here, we are always focusing to the correct hydratation of the tissue, the form of communication, the biomechanical part of the segment that we treat, and of course the clinical application with its respective description. For example, the biceps, it is the short video, how we perform the treatment, positioning towards the patient body, shown in this photograph and cross section. This is the last chapter of this book. The volume 2 will focus on the lower body. It is already finished and is in the process of revision and printing, so you will be able to enjoy it soon. Thank you for your presence. I would like to invite you to review the book, and if you like it, to buy it. Finally, I would like to express my gratitude to the Handspring Publishing team for the excellent treatment throughout the 5 years it took us to make this complex book. The editorial quality exceeds my expectation. I hope you enjoyed it. Bye-bye.